So I would like to invite Dr. Amar Pujari, who is doing a lot of squint and has published many papers, otherwise done a lot of research. And if you see his research, you will understand how innovative mind he has. So from him, we'll be listening today about the, aligning vision in thyroid eye disease, which is again a very, challenging situation for us also and for the patient to deal with.
Thank you, ma'am. Good afternoon, everyone. So I'll be speaking on how to align the eyes in thyroid eye disease. So I don't have any disclosures here. So as we know, this has been covered. Thyroid eye disease it has a lot of inflammation along the orbital muscles and the orbital tissue. So that's how it causes a restriction. So that's what it won't allow the extraocular movement properly. So that will lead to secondary contracture of the muscle. That's how we are going to get squint. So that leads to deviation, either esotropia or hypotropia, which is common. And because of that one, patient is going to have distressing diplopia. So that will lead to automatically head posture where patient wants to have a comfortable binocular single vision. So what is the incidence of strabismus in TD patients? It is somewhere between 17 to 51%. And diplopia could be the primary presentation by the patient in up to 15 to 20% of the thyroid eye disease patients. So whenever we encounter patient with diplopia or ocular deviation in a patient with thyroid eye disease, so what is the first thing we should do is we should document the amount of deviation using prism bar cover test. After that, we are going to assess the stereopsis and we are going to draw diplopia charting. So we want to see at the baseline how the thing is appearing double. So we want to monitor that one because at the end of 3 months, 6 months and 1 year, we want to serially follow up the patients and we want to see how the patient is either stabilizing his deviation or he is progressing. And at the same time, we are going to have a good systemic control. During initial stages, we are going to control the patient's systemic profile and we are going to ask him not to smoke. And to relieve diplopia, we can do other eye patching depending on the which eye is deviating more. That is going to relieve his diplopia. And if he has significant restriction, he might develop head posture, but that's how we are going to manage them initially. At least till he is going to stabilize systematically. After that, if the patient has very minimal deviation or up to 30 prism deviation, we can give glass prisms or Fresnel prisms. So that is the initial strategy. Some people are giving botulism toxin also, but we don't recommend it routinely. But the West people have given, and there is a published literature on this one. So they are basically, because we know that it's inferior rectus which is most commonly involved, followed by medial rectus, superior rectus, and the lateral rectus. So they are going to inject botulism toxin into the inferior rectus or the medial rectus, which can be done under topical anesthesia or peripulpar block. So often the literature agrees that they are going to give 5 units of botulism toxin into single muscle in single setting, and they might repeat up to 2 or 3 settings, and we can get an average correction of 15 prisms or even 20 prisms, not more than that. And it's of course it's going to recover over a period of time. So when to do surgical intervention? By and large, we need to have a stable systemic control. So then only we are going to assume that the orbital condition is not going to progress. So then patient is fit for the surgery. Most importantly for us, patient should be having a stable deviation for at least 6 months. So we can have at 4 months, but beyond 6 months is going to be the time where you are giving more time for the eye to stabilize, because it's a contracture. It's not some physiological change which is going to happen, because he can have recurrence, as Dr. Ashdip has said. So in those conditions, patient can have progressive increase in the deviation, even though previously it was stable for 3 months. So at least 6 months or even 9 months, you need to have a coordination with the endocrinologist. What is the hormonal profile, what is the clinical status, what is the clinical grading, and what is the oculoplasty people what they are saying, and most importantly what is your deviation or the diplopia charting says. If it is more than 6 months and the deviation is stable and the ocular feature there is no congestion, eye is quite good, then probably you can operate the eye. So how to operate these eyes? Most often we are going to get, of course, majority of the patients are adult patients only. We do under peribulbar anesthesia, not general anesthesia. Way to open the conjunctiva, as we said, it is the inferior rectus which is contracted most of the times, followed by medial rectus muscle. So we prefer limbal incision, because when you do force duction test on table, you will see that the conjunctiva will be severely tight and the muscle is going to be severely tight. So in those cases, there is no point in giving a pharyngeal incision, because you won't be able to pass your muscle hooks and you won't be able to retrieve the muscle. So in those cases, try to give a relaxing limbal incision. So try to open it in a rectangular fashion, and you can give the if for example if it is the inferior rectus, you can give the inferolateral or inferotemporal relaxing incision and inferonasal relaxing incision. That's how you can elevate the limbal conjunctival flap. So then you can dissect in each quadrant using tenotomy scissors. That's how it's going to give more space for your muscle hook maneuvering. Once you hook the hook the muscle, so try to retrieve the muscle and try to have a space at least 1 to 2 millimeter from the insertion, because you want to have a movement with the muscle hook. That's how you are going to put your sutures, because between the muscle hook and the sclera there should be 0.5 or 1 millimeter distance, because we are not going to suture at the sclera, we are going to suture onto the tendon. So while cutting the muscle, you should not be cutting the suture. So that's why take single arm, two single arm vehicle sutures, because if you cut one, other will be there. So if you are using only single arm vehicle suture, if you cut, you might lose the muscle, because muscle is contractile. It's a fibrotic contracted muscle, so it can go into the orbit. Of course, it won't be lost, but you can use two sutures, and of course that helps when, of course, these muscles are tight. Once you recess, once they are on the sclera as the recess point, if something happens, if the suture loosens post-operatively, once loosens out, another will be there. So that's how it is better to have two sutures, single arm sutures. You are suturing the muscle in each half using single sutures before disinserting and after like resuturing onto the sclera also. So congenital tightness will be there in all the patients, and try to recess the conjunctiva. That is the advantage of doing limbal based peritomy, because once you have taken out the rectangular shape flap, you try to recess the conjunctiva. Once you recess the muscle, try to recess the conjunctiva also, and just cover the muscle insertion and fix the conjunctiva onto the sclera at that point. The muscle stump should not be left bare. That should be covered, and you can suture the conjunctiva, and rest relaxing peritomy can also be sutured. And of course, as ma'am has said, orbital compression should be done first, because that can induce a lot of fibrosis and that can exaggerate your squint or the ocular deviation. So that is the first thing you should do. Then you can touch the extraocular muscles. Which surgery? So often by convention, as we do resections first followed by resections, but in thyroid eye disease and restrictive strabismus, for example DRS also, during retraction syndrome, so we don't prefer resections, but of course people are there who have described the resection procedure, but by convention we are going to follow the resection procedure. Most of the times it gives good correction, and rarely we have done resections, but resections are not preferred, because one thing is the muscle belly is going to be too thick. So when you are cutting the belly, it can bleed a lot, and most importantly, you are bringing the belly onto the insertion, so which can induce more redness in the post-operative period, because patient is going to have proptosis, he is going to have very large scleral show. So once you are bringing the muscle anteriorly, it can induce exaggerated redness, which can confuse your clinical scoring later. So what is the amount of recession? It is not fixed. What we are going to do is, like, once you have opened up the conjunctiva, you are able to hook the muscle and you suture that one. Let the muscle fall back because you have sutured this, and hold the muscle, hold the globe, and try to rotate in extreme elevation or depression for superior inferior rectus, and extreme abduction or adduction for medial rectus muscle. Leave it, and wherever it stays, it's going to stay in the middle, because you have taken out the relieving factor, because of course you have blocked, no muscle is active, so it is going to assume very least resistance position, which is the primary position. And let's see where the muscle is falling behind, right? So that is the point where you want to suture the muscle, and you just pass one suture and try to elevate the globe. If the muscle is not too tight, that is the position you are supposed to suture. If it is too loose, probably you are too posterior. If it is too tight, if it is not allowing the elevation, then probably the FDT is still tight. So that's how we are going to assume the appropriate recession procedure, because if the tip prism deviation is there, it's not 6 mm recession you are going to do. It's never like 6 mm, 5 mm, it's not fixed. So that is a key point in these patients. And whenever you are like doing inferior rectus recession, inferior rectus is an also adductor. In down gaze, it's going to give binocular single vision. I will show some of the examples. So that's why whenever you are doing inferior rectus recession, you need to nasalize the inferior rectus reinsertion. So if this is an inferior rectus insertion, you are recessing it, try to put it on nasal side, because the adductor function should not be lost. In down gaze, it can give adduction. So that's why we are going to have physiological V phenomenon. We can converge in down gaze. So don't do plain IR recession, do with nasalization. Otherwise, if you do pure IR recession, that can impair the adduction, that can give leverage to other eye supraoblique also. That's how we are going to have problem in the down gaze. So this is one of the patient, example 1, 45-year-old patient who was diagnosed with thyroid eye disease 5 years back, and you can see that left eye is significantly hypotropic, right? So he has more than 90 prisms of hypotropia, and what we plan is we will do an FTT for inferior rectus, then we'll open up the muscle and we'll see, right? So we open up the conjunctiva and muscle was severely tight, so we recessed. As I said previously, we applied the same technique, and this is what we get at the end of 3 months. So you can see that he has good correction, but still it's not acceptable, because patient has around 30 prisms of residual hypotropia in the left eye, and he's actually having still diplopia. So we thought of doing resection that might correct the upper lid this thing also, but somehow the resection was not that much palatable. And in down gaze also you can see that we have not lost the any uh, I mean, infraduction is not hampered. So he has good binocular single vision. He's a driver by occupation. So he should be having a good down gaze binocular single vision, because he'll be putting his foots on the foot pedal. So they should not have any confusion while driving. And at the same time, he should be having a single vision while driving at night time. So we observed him, and surprising, he came after 2 years. You can see that he is orthophoric on his own. So what is the cause for this one? So we didn't do any second surgery. There's something called progressive overcorrection in thyroid eye disease. So once you do the recession, so over a period of time that muscle becomes weak and the antagonist muscle is going to take advantage. So here that is what happened, progressive overcorrection has happened and patient has a good correction on his own. So he said like it happened around like 1 year and he is not having any diplopia, and most importantly, fortunately he doesn't have any diplopia in down gaze, and there is not much of a pattern or fusional inability in the down gaze, and the elevation is also good. So he has a good binocular single vision from up gaze to primary gaze to the down gaze, and he is very happy. Second patient, this was shown by Neela ma'am also. So I don't have the pre-op picture, you might have seen there. And it was ma'am's patient, and patient has taken Botox in bilateral middle rectus muscle, and he has also undergone trab in the right eye. He was a teacher by occupation. His complaints were like while he's teaching the distant things or the blackboard, when he's standing behind or the students, he sees the double, and even students are not comfortable with his looks. So that's why he insisted squint surgery. Of course, he has taken botulinum toxin that has induced fibrosis. Probably that has worsened the esotropia. And initially, we did left eye single MR recession, which was around 6 mm. And this is after first surgery. You can see that left eye is ortho, but right eye is still this thing. It has 1/60 vision. It has a functional bleb, and the bleb was on the nasal side because lateral scleral show will be there because of lateral flare. Superior temporal bleb is not there, so it was on the nasal side. So we were hesitant to do MR recession in the beginning, but after 1 year it got settled, and we did MR recession also. That after like bilateral surgery, you can see that he has around 8 to 10 prisms of residual esotropia in the right eye. Of course, he has 1/60 vision, but we tried prisms. He was comfortable for distance. He said that somehow the very dull image overlapping is not there. I am able to see the things clearly. Either he's going to improve the vision in the right eye, which is rare, or he might lose the vision, then he's going to have no diplopia. But as of now, he's comfortable with the prisms, and we have done bilateral middle rectus recession. And as I said previously, progressive overcorrection, he might go into consecutive exo. As of now, we are happy, but we should be thinking about the future as well. So this is the third patient where she had around 30 prisms of hypertrophy in the right eye. You can see all the lid features, and she's now stable, no ocular signs. And in the down gaze, you can see that she's enjoying her binocular single vision in the down gaze, right? So she's a homekeeper by occupation, but her concerns are like when she speaks to her colleagues, it's not acceptable. And most importantly, she's having double while looking at the television. So it's a primary gaze which is bothering her, and not the down gaze. And of course, we did surgery, we achieved binocular single vision in the primary gaze, but in extreme down gaze, we're having slight A pattern despite doing nasalization. And most importantly, we have slight introduction limitation in the right eye. So she said that like when she is like putting her foots on the footsteps, when she is climbing down, she has diplopia. So that's why she assumes much depressed head posture. That's how she negates. But otherwise, she is not functionally that disabled. But she is okay in the primary gaze and even to an extent in the down gaze. But in extreme down gaze, of course, we achieved in the primary gaze, but this is at the cost of extreme down gaze diplopia. So probably she is going to have progressive overcontraction in the suprarectus in the right eye also. She might end up with hypotropia, as we saw in the first case, and the second patient might end up with consecutive exo also. So this is a known entity. So residual deviation, as we saw in the second patient, that is one of the known concern or the complication. Diplopia in down gaze, as we saw in the third patient, again that is this thing. In first patient, we're fortunate we didn't get any diplopia. Progressive overcorrection because of secondary eye recession, which is a known entity in literature. It benefited in the first case, but it might cost us in the third case. It's a time which is going to decide. So mild head posture, as we said, the lady is going to depress her head, and she's going to have fusion in the down gaze, and she's going to work on that one. So lid retraction, damage due to excessive dissection. Once you do the inferior rectus dissection, don't do that one. Just hook the muscle at the insertion, expose only 5 mm, pass the sutures, and let everything fall behind. Don't try to do dissection along the inferior lid retractions. That can shag your like lid, and that can lead to excessive scleral exposure, or you can have pseudoproptosis. So as the surgical planning is never fixed, so surgical success is also not fixed, and we can see that up to 50% of the patients. So out of these 3 patients, 3 might come with for resurgery because of progressive overcorrection, or even when the disease is recurring, they might develop recurrent deviation. So resurgery rate is as high as 50%. So management of strabismus in TED includes a regular follow-up. You need to be dedicated towards patient, and we need to accept the whatever result is. We need to tell the patient that as of now it is okay, and we are going to do surgery for what reason. And once you achieve the correction, let us maintain the systemic control in a very coordinated way. If something goes here and there, they might have residual deviation or consecutive deviations, and you should be prepared for that one. Thank you.
Yeah, thanks, Dr. Amar. I think it was a very simplified presentation because I could understand or make most of the things from it. So, any questions? Yeah.
Yes, ma'am. So Botox initially they were given for the paralytic squints, ma'am. So for example, if there is a lateral rectus palsy, MR is developing contracture, or in the initial phase we give before developing the contracture, because we want to paralyze this muscle also, and that is going to work for 3 to 4 months. And meanwhile, we are going to feel that this is also going to increase, or it's going to improve its function. So for time being, we are paralyzing this one. So we are playing with the innervation. It's a toxin to the nerve. We are not playing with the muscle fibrosis. So that is the reason why we are giving botulism toxin. We want to paralyze the antagonistic or overacting muscle. But here it is a fibrosis. It is nothing to do with the innervation. So already because of chronic inflammation, the myofibrils are going to have fibrosis, ma'am. So if you are going to inject the toxin into the muscle, and there are histopath studies also previously when they injected toxin into the rabbit eye muscles, there was a fibrosis. Of course, they are playing at the nerve plate end, but there is a fibrosis. So there is a hypothetical scenario that this can exaggerate the medial rectus fibrosis. I don't have any idea, ma'am. Yes, ma'am. Overcorrection. It's a double-edged sword, ma'am. Because if you do undercorrection, that can pull the infectus over a period of time. He might end up with residual correction. But yes, ma'am. Yes, ma'am. And the advantage of keeping in the primary case is he is having binocular fusion. So the fusion is going to drive the innervation. So that's how he'll be able to fuse, and he'll be able to focus onto the things. That's how it might maintain the binocular single vision in the primary case. If he's having undercorrection or overcorrection, that is going to create diplopia. That is going to inhibit the fusion. The fusion can change the innervation. So patient can run easily here and there. Either undercorrection, which can increase, overcorrection, which can increase. Yes, ma'am. Yes, sir. So there is a high chance that it can develop in all sort of patients. So in one patient, it benefited us. So if that patient would have primary in first, post-op day itself, he would have ended up with hypertropia. So fortunately, we have not seen, and even we have searched for the literature, it is not that common. But they say, sorry, sir. Yes, sir. But the because we saw that one, and people have said that one, and we are not like giving any leverage to the superrectors by doing, excessive amount of radiation. We want to be, managing the things. It is like playing with the bullock cart. We don't want to, weaken any of the range, right? So we want to be in the physiological range.